Welcome to this session on principles of screening in primary care. Today we approach screening not as a list of tests to memorize, but as a disciplined, evidence-based process that demands clinical judgment, ethical reasoning, and an understanding of our Caribbean context. Screening is one of the most powerful tools available to primary care. If it's done well, it detects disease before symptoms arise, allows earlier and more effective intervention, and critically reduces suffering and premature death at a population level. If it's done poorly, it wastes scarce resources, harms patients through false positive anxiety and overtreatment, and erodes trust. By the end of this session, you should be able to apply screening logic to your own primary care consultations, evaluate the quality of any screening program, and critically appraise recommendations in light of the realities of Caribbean health systems. Sources for this session draw on World Health Organization, the U.S. Preventive Services Task Force, PAHO, the Jamaican Ministry of Health and Wellness, and peer-reviewed Caribbean cancer control literature. Before we examine the specific criteria that govern screening, let us establish the fundamental rationale. Why does screening belong at the center of primary care? Screening matters because it converts a passive, reactive health system into a proactive one. Instead of waiting for patients to present with symptomatic disease, often at an advanced stage, less treatable stage, screening allows us to identify risk and disease in the preclinical window when intervention can meaningfully alter the outcome. There are three pillars to the value of screening in primary care. First, finding disease earlier. Screening should only be offered when detecting a condition earlier genuinely improves outcomes. It is not sufficient for a test to detect a disease early. The earlier detection must translate into reduced morbidity or mortality. Second, preventing complications. Screening is never a standalone act. A positive screen must trigger a reliable pathway of confirmatory diagnosis, treatment, and structured follow-up. Without this downstream infrastructure, screening becomes a source of anxiety with no benefit. Third, closing equity gaps. Routine clinic attendance skews towards those with better access, those who are healthier, better resourced, and geographically closer to services. Registers, recall systems, and community outreaches are the tools that extend screening to those who rarely attend. Equity is not a bonus, it's a moral obligation of any screening program. With that rationale established, let us be explicit about what you are expected to achieve by the end of this session. This session has 5 core learning outcomes, and together they build towards a single clinical competency, the ability to decide when screening is high value, when it is low value, and when it is actively harmful. The first outcome is conceptual. You should be able to explain the Kastic, Wilson, and Junger's screening criteria, understand why they remain foundational, and articulate what modern governance frameworks adds to them. The second is quantitative. You should be able to interpret sensitivity, specificity, positive predictive value, and negative predictive value, and understand how these statistics behave differently depending on the prevalence of disease in the population you are screening. The third is critical. You should be able to evaluate the harms of screening, including false positives, false negatives, overdiagnosis, and overachievement. They are not rare edge cases. They are inherent features of any screening program and must be communicated honestly to patients. The fourth is comparative. You should be able to examine a global recommendation from the WHO, the U.S. Preventive Task Force, or PAHO, and assess how applicable it is to Caribbean clinical setting, take into account available technology, diagnostic capacity, cultural acceptability, and pathway completeness. Finally, the fifth is practical. You should be able to design upstream, midstream, and downstream strategies to improve both the equity and the completion rate of a screening program. This is an applied postgraduate session. We expect you to engage with complexity, not simplify it away. To apply these outcomes correctly, we must first be precise about what screening actually is and how it differs from closely related activities that are often confused with it. This distinction is not merely academic. Misclassifying a clinical activity as screening when it is actually diagnostic testing or surveillance leads to misapplication of evidence, inappropriate use of resources, and potential patient harm. Screening is the systematic application of a test to an apparently healthy asymptomatic population to identify individuals at higher risk of a condition with the intent of triggering confirmatory investigation. The key word is asymptomatic. Screening operates in the preclinical phase. If a patient already has symptoms, they are no longer a screening candidate. They need diagnostic workup. Case finding is related but distinct. This is an opportunistic detection occurring during consultation the patient has attended for another reason. The patient presenting for hypertension review who is then offered a fasted blood glucose based on their age and BMI is being case found, not screened in the formal programmatic sense. Diagnostic testing starts from a different premise. There is already a symptom, a sign, or an abnormal result that raises the pre-test probability of a disease. The purpose is to confirm or exclude a diagnosis, not to search a low-risk population. Surveillance differs in that it monitors an already diagnosed condition, a known high-risk state, or a previously treated disease. Colonoscopic follow-up after polyp removal is surveillance. Annual retinal examination of a known diabetic is surveillance. The clinical pearl on this slide is worth memorizing. A positive screen is not diagnosis. It is a signal. The work of confirmation, interpretation, and management still lies ahead. Now that we know what screening is, the critical question becomes, how do we decide whether a particular disease warrants a screening program at all? In 1968, Wilson and Junger, writing for the World Health Organization, published a landmark set of 10 criteria for evaluating whether a condition was suitable for screening. Over 50 years later, their framework remains the starting point of any serious evaluation of a proposed screening program. The criteria cluster into 4 domains: the disease, the test, the treatment, and the program. Regarding the disease, it must be an important health problem. Rarity alone may disqualify a condition. There may be a recognizable latent or early symptomatic stage, the preclinical window which we are trying to exploit, and the natural history must be sufficiently understood so we know that earlier detection genuinely improves outcome. Regarding the test, it must be acceptable to the population being screened, safe, valid, accurately measures what it claims to measure, and reliable, produces consistent results. Critically, there must be a clear agreed threshold that separates normal from abnormal results and a defined pathway for what happens after an abnormal finding. Regarding treatment, an effective and accepted intervention must exist. Screening for a condition for which no effective treatment exists may cause harm without benefit, labeling patients, inducing anxiety, and triggering unnecessary investigation. Regarding the program, the cost effectiveness must be demonstrated. The program must be continuously quality assured. It must be equitable in its reach, and it must be monitored and sustainably funded. The decisive rule on this slide is, do not start a screening program unless the downstream system, diagnostic, treatment, and follow-up, can absorb the positives it will generate. This is the principle that most frequently fails in Caribbean settings. Wilson and Junger's program domain points to something crucial. Screening is not an act, it's a process. Let's make that process explicit. One of the most common errors in primary care screening is treating the test as the end point. The test is not the end point, it's the entry point. A well-designed screening program has at least 5 sequential steps, each of which must be designed, resourced, and measured. Failure at any step converts the potential benefit of earlier detection into a burden on the patient. The first step is invitation. Who is eligible and how should they be identified and contacted? This requires a register, a list of eligible population, and a method of reaching them. The second step is testing. What test will be used? What are its operating characteristics, and is it acceptable to the population? Acceptability is not trivial. A test that patients refuse does not screen anyone. The third is confirmation. When a screen is positive, what confirmatory diagnostic pathway is available? Is it timely? Is it accessible? In many Caribbean settings, the bottleneck lies here. The screening test exists, but the confirmatory pathway, colposcopy, colonoscopy, biopsy, specialist review, is delayed, distant, or costly. The fourth step is treatment. Can the system act on confirmed positive findings? Is there surgical, medical, or ablative capacity? Are waiting times clinically acceptable? The fifth step is recall. Who ensures that patients who screen positive are not lost to follow-up and are brought back to the system? Recall is an active, named function. It does not happen by default. The failure of any one step converts the entire program from a net benefit to a net burden. This is the program logic that should guide quality improvement in any Caribbean primary care setting. To evaluate any screening test, you must be comfortable with its quantitative operating characteristics. Let's work out the fundamental framework. The 2x2 contingency table is the foundation of the test performance analysis. On one axis, you have the true disease status, disease present or absent. On the other axis, you have the screening test result, positive or negative. The resulting four cells this creates are the true positive, the false positive, the false negative, and the true negative. And those are the basics for all statistics that follow. Sensitivity is the proportion of people with the disease who have test positive. The highly sensitive test rarely misses the disease. Mathematically, sensitive is equal to true positives divided by true positives plus false negatives. When sensitivity is very high, a negative result is particularly valuable. It largely rules out the disease. This is the logic of the SNOUT rule. Sensitive test, negative results rules out disease. Specificity is the proportion of people without disease who test negative. A highly specific test rarely produces a false positive. Mathematically, specificity is equal to true negatives divided by true negatives plus false positives. When specificity is high, a positive result is particularly meaningful. It largely rules in the disease. This is the SPIN rule. Specific test, positive result, rules in disease. There is an inherent trade-off between sensitivity and specificity. Moving a test threshold to capture more true positives, increased sensitivity, will typically also capture more false positives, reduce specificity. The appropriate balance depends on the clinical context, the severity of the disease, the harms of misdiagnosis versus false alarms, and the cost of confirmatory testing. One important caution: SNOUT and SPIN should be used carefully in real-world screening because these rules assume the test is being applied in a population whose characteristics match those in which it was validated. Prevalence, which we turn to next, changes everything. Understanding sensitivity and specificity gives you the intrinsic properties of a test. But the statistic your patient cares about, and the one that determines whether a positive result demands action, is the predictive value. Predictive values answer the question from the clinician's perspective. Given this result, what is the probability that the patient truly has or truly does not have the disease? Positive predictive value is the probability that a patient with a positive screen truly has the disease. Negative predictive value is the probability that a patient with a negative screen truly does not have the disease. Unlike sensitivity and specificity, which are intrinsic properties of the test itself, positive predictive value and negative predictive value are critically dependent on the prevalence of the disease in the population being screened. Consider the worked example on this slide. A test with 90% sensitivity and 95% specificity, both excellent by most standards. If this test is applied in a population where the disease prevalence is only 1%, positive predictive value is just 15%. This means 85% of the people who screen positive do not have the disease. Most positives are false positives. The investigation, anxiety, and cost generated by a positive result is largely borne by people who are, in fact, well. Increase the prevalence to 10%, and the positive predictive value rises to 67%. At 30% prevalence, as might occur in a high-risk group, the positive predictive value reaches 89%. The Caribbean implication is direct and practical. By targeting screening to genuinely high-risk groups, older age, family history, prior exposure, comorbidities, we improve the yield of a positive result and reduce the burden of unnecessary follow-up. Risk stratification is not a compromise of equity. It is a conservation of scarce diagnostic capacity while maximizing the value of each test performed. Now we have examined how to measure test performance. But performance statistics do not capture the full picture. Screening also has harms, and these must be understood and communicated. Medical training devotes considerable time to the benefits of screening: earlier detection, improved survival, reduced complication. It devotes far less time to the harms. This imbalance is reflected in clinical practice, and it undermines the ethical obligation of informed consent. Overdiagnosis is arguably the most complex and consequential harm. It refers to the detection of a disease that would have never caused symptoms or death in the person's lifetime, either because the disease was so slow-growing that something else would have killed the person first, or because the abnormality would have regressed spontaneously. Overdiagnosis leads directly to overtreatment, surgery, radiation, chemotherapy, or surveillance for a condition that posed no real threat. Overdiagnosis is not a screening failure in the technical sense. It is a fundamental consequence of finding more disease when you actively look for it. False positive cause anxiety, trigger invasive confirmatory investigations, generate cost, and can carry stigma, particularly for conditions with sexual or behavioral connotations, such as HPV infection. The patient experience of a false positive is often described as one of the most distressing healthcare events they have encountered. False negatives provide false reassurance. A patient told that they screened negative may delay presenting with symptoms, assuming that they were recently checked. This erosion of trust, when a cancer is subsequently diagnosed shortly after a negative screen, can be lasting. Opportunity cost is a population-level harm. Resources committed to a low-yielding screening program are unavailable for higher-yield interventions elsewhere in the health system. The ethical rule that follows from all of this is non-negotiable. Informed choice requires communicating harms and not only benefits. The patient cannot consent to screening unless they understand what a positive result means, including its uncertainty. The harms we have just reviewed do not simply represent technical imperfections, they create genuine ethical obligations. Let us apply the principles of biomedical ethics to the screening context. Screening is unusual in medicine because we initiate an intervention in people who have not come to us with a complaint. They are asymptomatic. We approach them. This reversal of usual clinical relationship creates heightened ethical responsibilities. Autonomy demands that individuals are given sufficient information about the benefits, harms, and uncertainties of a screening program to make a genuinely free decision, including the right to decline without penalty or judgment. This is informed choice, not informed consent for a therapeutic procedure. The framing must be appropriate to an asymptomatic person who may be well. Beneficence requires that the evidence of meaningful benefit is robust. It is not sufficient that screening detects disease earlier. Earlier detection must translate into improved outcomes for a meaningful proportion of people screened. When this evidence is weak or contested, offering screening is ethically questionable. Non-maleficence requires active steps to minimize false positives, false negatives, overdiagnosis, and unnecessary procedures, not to accept them as inevitable. Program design, test threshold selection, and quality assurance are all expressions of non-maleficence. Justice requires that the invitation, testing, confirmation, treatment, and follow-up components of the screening pathway are equitably accessible. A program that screens only those who attend well-resourced clinics during business hours and fails to reach rural, low-income, uninsured, or digitally excluded populations is unjust, regardless of its technical quality. Finally, accountability requires robust quality assurance, audit, privacy protection, and data governance. The screening program must measure its own performance and correct its own failures. In the Caribbean lens, equity is the justice dimension that most frequently demands attention. Screening pathways must be designed to function for populations who face structural barriers to care. With the ethical and statistical foundation in place, we can now turn to specific screening recommendations and the discipline of adapting them to the Caribbean context. Global recommendations from the World Health Organization, the United States Preventive Service Task Force, and PAHO represent the best available synthesis of evidence from large, well-resourced populations. They are invaluable anchors, and they are not scripts to be followed without adaptation. Each recommendation was developed in a specific epidemiological, economic, and health system context. Before applying any recommendation in a Caribbean primary care setting, you must ask, does the burden of disease here match the population in which this recommendation was developed? Is the recommended test available and of adequate quality? Does the confirmatory diagnostic and treatment pathway exist and function reliably? Is this recommendation acceptable to our patients? For cervical cancer, the World Health Organization recommends HPV DNA testing from age 30 every 5 to 10 years in the general population and from age 25 every 3 to 5 years in persons living with HIV. HPV DNA testing is more sensitive than cytology and supports longer intervals, a practical advantage in settings which constrained clinical capacity. For breast cancer, the U.S. Preventive Service Task Force 2024 recommendation advises mammography every 2 years for women aged 40 to 74. This requires functioning mammography equipment, radiological quality assurance, access to biopsy, and an oncology pathway, a substantial systemic requirement. For colorectal cancer, both the U.S. Preventive Services Task Force 2021 recommendation and the Latin American and Caribbean Code Against Cancer suggests initiating screening at age 45 to 50 with fecal immunochemical testing, FIT, or colonoscopy. FIT-first approaches may be more scalable in settings where endoscopy capacity is limited. Hypertension and diabetes screening represent high-value, low-cost opportunities in primary care. The infrastructure requirements are minimal and the downstream interventions, antihypertensives, lifestyle modifications, metformin are widely available. These should be systematically applied. The best practice rule, local adaptation should be explicit, documented, and subject to audit. Adapting global recommendation requires honest engagement with the specific implementation challenges of Caribbean health systems. Let us examine these using a structured framework. The AAAQ framework, availability, accessibility, acceptability, and quality, provides a practical lens for assessing whether a recommendation can be genuinely implemented in a given setting. Availability asks whether the physical and human resources exist. Is the screening test available? Are the laboratories, imaging, or procedural facilities present? Are trained staff deployed? Are medicines and treatment modalities in stock? In Caribbean settings, availability gaps may include limited colposcopy services, restricted colonoscopy capacity, and variation in oncology service provision across islands and regions. Accessibility asks whether the available resources can be reached by those who need them. Transport costs and time, clinic opening hours, referral waiting times, direct cost of tests and consultations, and the particular geographic challenges of island and rural settings all affect accessibility. A mammography machine that exists only in a private capital city facility is not truly accessible to a rural, low-income woman. Acceptability addresses the social and cultural dimensions of screening uptake. Fear of a cancer diagnosis, stigma associated with certain screening tests, particularly those involving genitourinary examinations, gender norms that affect who accompanies a patient, religious or cultural beliefs about the body, and mistrust of the health system born of historic negative experiences. All of these suppress uptake among populations that most need to be reached. Quality concerns the consistency, reliability, and audit readiness of the screening process. Standardized protocols, functioning recall systems, accurate registries, timely diagnostic completion, and active monitoring of outcomes. Without quality assurance, even available and accessible screening generates noise rather than signal. The insight from the Caribbean literature is that the problem is really the complete absence of screening. It is fragmented, opportunistic, and even completion screening that starts but does not finish the pathway. Let us now apply these principles to the most thoroughly evidenced cancer screening opportunity in the Caribbean, cervical cancer. Cervical cancer represents close to an ideal candidate for a screening program by Wilson and Junger's criteria. The natural history is well understood. Persistent high-risk HPV infection leads to progressive cellular changes, CIN, over years to decades before invasive cancer develops. This preclinical window is long, offering multiple opportunities for detection and intervention. The precancerous lesion, cervical intraepithelial neoplasia, is treatable with ablative or excisional procedures that are effective, relatively straightforward, and widely feasible. Early-stage invasive cancer is also highly treatable. HPV DNA testing is the most accurate first-line screening test available. It is more sensitive than cytology, the pap smear, and visual inspection with acetic acid, and its high sensitivity supports longer screening intervals, an operationally significant advantage. Self-sampling for HPV testing has been shown to maintain diagnostic accuracy while reducing the barriers of clinic attendance, embarrassment, and bottlenecks in clinical capacity. Screen and treat models where a positive HPV test leads directly to ablative treatment at the same visit rather than waiting for corpuscular confirmation can be considered in settings where loss of follow-up between screen and treatment is high, provided appropriate clinical safeguards are in place. The prevention to treatment pathway is well defined. HPV vaccination and sexual health education form the upstream preventive layer. HPV DNA testing, cytology, or VIA form the screening layer depending on resources setting, risk-based triage, and referral management of abnormal results, and ablation, excision, or the oncology pathway manages confirmed disease. One critical communication issue: a positive HPV test is not cancer. It is not even necessarily precancer. Clear, non-stigmatizing communication is essential, particularly given the association between HPV and sexual transmission, which can cause misunderstanding, shame, and damage to relationships. Cervical cancer screening has a relatively clear evidence base and a well-defined pathway. Other major cancers present more nuanced clinical and programmatic decisions. Breast cancer screening through mammography has a moderate evidence base for mortality reduction, but the benefit is contested in terms of magnitude, and the harms, particularly overdiagnosis and overtreatment, are well documented. For Caribbean primary care, the critical question is systematic. Does the radiological quality assurance exist? Is biopsy accessible? Is there a functioning oncology pathway for confirmed cases? Offering mammography without this downstream infrastructure is ethically problematic. Shared decision-making, a genuine conversation about its benefits, harms, and the patient's values, is the appropriate model wherever capacity for that conversation exists. Colorectal cancer screening should begin at age 45 in average-risk adults, based on both the U.S. Preventive Services Task Force 2021 recommendation and the PAHO WHO Latin American and Caribbean Code Against Cancer 2023. Fecal immunochemical testing or fecal occult blood testing are stool-based tests that are non-invasive, inexpensive, and logistically scalable, making them a more realistic first-line approach in settings where colonoscopy capacity is limited. Colonoscopy remains the definitive diagnostic and surveillance tool, but a FIT positive then colonoscopy pathway may be the most pragmatically achievable entry point in many Caribbean settings. Prostate cancer screening with PSA, prostatic specific antigen, remains one of the most debated areas in preventive medicine. PSA has a high false positive rate. It detects many cancers that would have never caused clinical problems during a man's lifetime, overdiagnosis, and the resulting treatment, radical prostatectomy, radiotherapy, hormone therapy, carries significant morbidity. No major guideline currently recommends population-level PSA screening. The preference-sensitive approach is structured, balanced discussion of benefits and harms, allowing the individual to decide, is the model supported by the U.S. Preventive Services Task Force and most international bodies. The unifying principle for all three cancers: prioritize screening programs where the full diagnostic and treatment pathways can reliably be completed. Having discussed the technical and clinical dimensions of specific screening programs, let us return to the equity dimension and make it more precise. Equity in screening is commonly operationalized as uptake, that is, what portion of eligible persons were screened. This is necessary but far from sufficient. A program can achieve high uptake while being profoundly inequitable if certain groups consistently fail to complete the pathway beyond the initial test. The full equity cascade has 6 steps. The first is eligibility. Those who have been defined as eligible and the criteria themselves equitable. Age thresholds that exclude younger high-risk individuals or gender-based eligibility that excludes transgender patients represent equity failures at a point of program design. The second step is invitation. Was the person actually reached? Were invitations sent in accessible formats, in appropriate languages, to correct addresses? Were hard-to-reach groups, those without fixed addresses, those without digital access, those in remote areas, were they actively sought out? The third step is the test itself. Did the person attend and complete the test? Barriers here include transport, cost, fear, stigma, and clinic hours. The fourth step is communication of results. Was the results communicated and was it understood? Health literacy varies. A result communicated only in writing to a low literacy patient has not been effectively communicated. The fifth step is diagnostic confirmation. When a screen is positive, was confirmatory investigations completed? This is a frequent failure point. Referrals are made but not attended, waiting times are excessive, or the patient cannot afford the confirmatory test. The sixth step is treatment initiation. Was care actually started? Even a fully diagnosed patient may not receive treatment if financial, logistical, or system barriers intervene. The equity audit questions on this side are designed to be used in practice. Who was not invited? Who screens positive but disappears? Was the longest delay? Which group have lower completion? These are questions that quality improvement in Caribbean screening must answer. So what can we do as an individual clinician in a primary care consultation to improve the quality and equity of screening? Individual level strategies in primary care are powerful precisely because they happen one patient at a time in a relationship of trust. 5 evidence-based approaches deserve emphasis. Risk stratification means using available information, such as age, sex, family history, HIV status, smoking, body mass index, prior screening history, and symptoms, to identify which patients are at elevated risk and should be prioritized for screening. This does not mean refusing screening to lower-risk patients. It means ensuring higher-risk patients are not missed, and understanding that a positive screen in a high-risk patient has a higher predictive value. Shared decision-making for preference-sensitive screening, particularly prostate and increasingly breast, means presenting both benefits and harm in accessible language and genuinely inviting the patient to make a decision aligned with their own values. This is not a disclaimer exercise. It's a clinical conversation. Reducing friction means removing barriers within your control. Same-day testing when a patient is in front of you and the test can be performed, standing orders and nurse-led protocols that do not require physician involvement for routine screening, and reminder calls for an overdue patient. Every additional step between eligibility and testing is an opportunity for non-completion. Closing the loop means not merely performing and documenting the test, but ensuring the results is communicated clearly. The patient understands what it means, and the next step, whether routine recall or urgent follow-up, is booked before the patient leaves. Countering misinformation means actively asking patients what they have heard about the test, particularly relevant for cervical screening, HPV and infidelity, mammography, radiation causing cancer, and PSA screening, it always means cancer, and correcting misconceptions without shaming. The microscript on this side is worth adapting for your own practice. This test can help us find disease early, but it can also lead to extra tests that may not be necessary. Let's decide based on your risk and what follow-up is possible. Although individual consultations matter enormously, sustainable, equitable screening improvement requires action at the system level as well. Let us use the upstream, midstream, downstream framework to organize population-level strategies. This model, the upstream, midstream, downstream model, is a useful tool for thinking about where in the causal chain an intervention acts and who is responsible for delivering it. Upstream interventions address the root determinants of a disease and health system capacity. HPV vaccination programs reduce the incidence of the disease we screen for, making the entire cervical screening enterprise more effective over time. Tobacco control policies reduce the burden of lung, bladder, and cervical screen and cancer. Food and built environment policies reduce obesity-related cancer risk. Sustainable financing mechanisms ensure that screening programs do not depend on intermittent donor funding. Public education builds health literacy and normalizes screening behavior. These upstream interventions are largely the domain of the government and public health policy, but primary care clinicians can advocate for them and communicate their importance. Midstream interventions act at the level of primary care delivery systems. Disease registers that identify who is eligible and due for screening are the foundation. Recall systems, systematic named processes for contacting patients who are overdue, convert one-time screening events into longitudinal programs. Community outreach extends the reach of the health system to those who do not attend the clinic. Self-sampling options for HPV testing reduce the acceptability barrier. FIT kits distributed through community channels bypass the need for clinic attendance. Task sharing, such as enabling nurses and community health workers and midwives to deliver screening functions previously reserved for physicians, dramatically increases capacity. Downstream interventions ensure that the diagnostic and treatment pathway is completed. Rapid diagnostic pathways reduce the time between an abnormal screen and a confirmatory investigation. Patient navigation, a named person responsible for following a screened positive patient through the system is one of the most evidence-based strategies for reducing loss to follow. Referral tracking systems ensure that referrals are made, referrals completed. Treatment access and survivorship support complete the care continuum. The strategic summary on this slide captures the shift we need to achieve in Caribbean primary care. Screen less randomly, screen more reliably. Let us now translate these population-level strategies into a concrete, practical roadmap for establishing or improving a screening program within a primary care clinic. This six-step implementation roadmap is designed to be actionable at the clinic level without requiring national-level resources or infrastructure. Step 1. Define eligibility. For each condition you plan to screen for, create explicit criteria: the age range, sex, comorbidities, prior screening history, and define who is excluded, that is, those already in a surveillance program, those with a prior diagnosis. This creates a denominator, the population you are responsible for. Step 2. Build a registry. A register is a list of your eligible patients. In its simplest form, this can be a spreadsheet. Each patient should have a flag for whether they are due, overdue, or up to date on each relevant screening test. Without a register, your program is entirely dependent on patients presenting themselves, which means those with the most barriers to attend will be missed. Step 3. Standardize invitation. Decide how you will contact eligible patients. SMS reminder, telephone call, opportunistic prompting at every clinic attendance, community health worker outreach. Standardization means the invitation is not dependent on any individual clinician memory. Step 4. Test and document. Use checklists to ensure the test is performed consistently. Templates and standing orders reduce variation. Coded fields in your clinic record allow audit. Step 5. Track positives. Every patient who screens positive must have a named responsible clinician or navigator. Their result must be recorded in an abnormal result log, and there must be a defined escalation pathway if referral is not completed within a specific time frame. The tracker is the safety net. Step 6. Audit outcomes. Monthly or quarterly audit of coverage. What proportion of eligible patients were screened? Positivity rates, diagnostic completion rates, waiting times, and equity gaps enable continuous improvement and accountability. The minimum viable system, the baseline that every clinic should have before claiming to offer screening, is an eligibility list, a reminder system, an abnormal result tracker, and a monthly audit. We have covered the theory, the statistics, the ethics, and the implementation principles. So now let's apply everything to a real-world case scenario. The patient is a 49-year-old woman attending for hypertension follow-up. She has not had cervical screening for 12 years, which places her squarely in the overdue category for a high-value screening opportunity. She works shifts, limiting her availability for clinic appointment. She has limited transport, making return visits a genuine logistical burden. And she holds a belief, based on incomplete understanding, that HPV testing means infidelity, which represents a misinformation barrier that requires a culturally sensitive response. Your group task is to design a screening plan that is clinically sound, culturally safe, and operationally realistic. Question 1 asks you to determine what screening is indicated, given her age, 49 years old, sex, and 12-year gap since the last cervical screening. Cervical cancer screening is clearly indicated. You should also consider whether hypertension management, diabetes risk, and possibly colorectal cancer screening, since she's approaching the threshold age, warrant attention in this consultation. Question 2 asks about barriers, transport, shift work, HPV stigma, and, implicit in her absence from care for 12 years, possible generalized disengagement from the health system. Each barrier has a potential solution. Question 3 asks how you will explain the benefits and harms. This is an informed choice conversation, not a recommendation to comply. You should communicate the purpose of the test, what a positive result means, and what does it not mean, particularly regarding infidelity, the possibility of false positives, and what follow-up would involve. Question 4 asks what system steps prevents loss to follow. This is where the implementation thinking comes in. If she is offered same-day self-sampling and a result is communicated by phone with follow-up booked before she leaves, the probability of completing is higher than if she's asked to make a separate appointment. As we close, let me offer you a practical decision tool that synthesizes the session's key principles into a format you can use at the point of clinical decision making. The VALUE framework provides a 5-question checklist for evaluating any proposed screening activity in primary care. V. Valid test. Is the sensitivity and specificity of this test appropriate for the purpose? Does the trade-off between the false positive and false negative align with the clinical context, the severity of the disease, the harms of misdiagnosis versus false alarm, and the capacity of the follow-up pathway? A. Actionable results. If this test returns an abnormal result, is there a confirmatory diagnostic pathway available, and is an effective treatment accessible? A result that cannot be acted upon should not be generated. L. Low harm. Has the program been designed to minimize false positives, false negatives, overdiagnosis, and overtreatment? Are these harms being actively measured and reported? And are they being communicated to patients as part of informed choice? U. Uptake with equity. Are hard-to-reach groups, rural, low-income, uninsured, digitally excluded, linguistically marginalized, actively invited and supported to participate? Is equity being measured at every step of the cascade, not just the point of initial uptake? E. Evaluated pathway. Is the full cascade from invitation through to treatment initiation and long-term outcome being audited? Are coverage, positivity rates, diagnostic completion rates, and equity gaps being tracked and reported? Is the program being held accountable to its results? The final message of this session is this: screening is a public health intervention delivered one patient at a time. The discipline you bring to each individual consultation, the risk assessment, the informed conversation, the same-day test, the result communicated and followed up, is the mechanism through which population health improvement actually happens. The following were carefully selected references which form the core reading for this topic. The references represent the foundational literature for screening principles and global recommendations in this session. We have the WHO Regional Office for Europe 2020 Guide on Screening Programs, which was the primary source for the program logic and ethical framework used throughout the session. It is the most concise and authoritative synthesis of modern screening governance available, and all students are encouraged to read it in full. The WHO 2021 Guidelines for Cervical Precancer Screening and Treatment is the definitive reference for cervical cancer screening, provided graded recommendations based on systematic reviews across resource settings. It forms the basis for the cervical cancer content in slides 11 and 13. The United States Preventive Services Task Force 2024 Breast Cancer Recommendations and 2021 Recommendations for Colorectal Cancer, Prediabetes, and Type 2 Diabetes and Hypertension represent the most rigorously developed clinical practice guidelines for primary care screening globally. They are also most frequently updated, and students should verify that they are consulting the most current version at the time of clinical application. Trevitan 2017 and Morgana et al. 2021 provide accessible, peer-reviewed accounts of sensitivity, specificity, and predictive values, the statistical foundation covered in slides 7 and 8. These are recommended readings for any student who wants to deepen their quantitative reasoning about test performance. All references are formatted for teaching use. Students should verify local clinical guidelines before applying any recommendation in practice, as national or regional adaptations may apply. The PAHO WHO Latin American and Caribbean Code Against Cancer is the regional equivalent of the European Code Against Cancer, a policy document and clinical reference that provides evidence-based recommendations specifically adapted for the Latin American and Caribbean context, including cervical and colorectal cancer screening. The Jamaica Ministry of Health and Wellness 2020 National Screening Guidelines and the 2025 update represent the most directly relevant national policy documents for many students in this program. These guidelines set the standard for what should be offered in Jamaican primary care, and students practicing in Jamaica are expected to be familiar with their content. Glasgow et al. 2022 in the Lancet Regional Health Americas provides an important epidemiological overview of the cancer burden in the Caribbean, including analysis of where the greatest opportunities for improvement lie. Its framing of further opportunities to reverse the disease trend reflects the evidence that cancer detectable through screening represents a disproportionate share of the Caribbean cancer burden. Telesford et al. 2025 on the Caribbean Cancer Portal discusses the lessons from building a sustainable, accessible cancer intelligent resource for the Caribbean islands, highly relevant for those working in cancer control or program development. The UK National Screening Committee criteria are referenced and an important comparator to Wilson and Jongleurs, providing more explicitly programmatic and governance-focused set of appraisal standards. For students practicing in Trinidad and Tobago specifically, a recommended local add-on is the Trinidad and Tobago Ministry of Health Screening Protocol and Regional Referral Pathways. These should be consulted alongside global and Jamaican references for locally specific guidance.